Hello, Kirkwood OTA students. We're second year OT students at St. Ambrose University. My name is Keegan.
My name is Kara.
My name is Maddie.
My name is Kennedy, and we will be providing a lecture on the scope of occupational therapy and stroke rehabilitation.
This is an outline of what will be discussed today. We will first begin with an introduction to the diagnosis, followed by evaluation information, which includes assessments that are appropriate for this population, evidence-based interventions for best OT practice, a case study scenario that allows you to apply your knowledge to a real life scenario, outcomes including adaptations that may be appropriate for this population, and lastly, a check your knowledge quiz that you may take at the end of this presentation. Introduction to the diagnosis. A stroke is also known as a cerebral vascular accident, or CVA. A stroke is a neurological event that occurs in the vascular origin of the brain that impacts overall functioning. When a stroke occurs in one hemisphere, it often causes dysfunction to the contralateral side or opposite side through hemiparesis, also known as weakness, or hemiplegia, also known as paralysis. Some possible deficits that may occur after a stroke event has occurred include sensory impairments, including loss of sensation or neglect, cognitive impairments, including language deficits or executive functioning deficits, or motor impairments, including spasticity or plasticity, and weakness.
For etiology, an ischemic stroke is caused by insufficient blood flow to the brain. It's most commonly from obstruction resulting from a blood clot, also called a thrombus, or an embolism. It can also result from blood flow reduction, such as during a cardiac arrest, and this type accounts for about 87% of all strokes. A hemorrhagic stroke is caused by a rupture of a weakened blood vessel, and its most common causes are aneurysms and arteriovenous malformations. Transient ischemic attack resembles a stroke, and it usually happens suddenly and can last up to 24 hours, but typically resolves with no deficits. And then risk factors for a stroke. Non-modifiable risk factors include age, gender, race, ethnicity, and genetics. And modifiable risk factors include hypertension, diabetes, heart rhythm disorders, high blood cholesterol, cigarette smoking, obesity, and lifestyle factors such as physical inactivity and a poor diet. For stroke precautions, we first just wanted to bring your attention to the FAST acronym to know if someone is experiencing a stroke. It stands for face drooping, arm weakness, speech difficulty, and time, because it's important to get that individual medical attention as soon as possible. You should also be aware of, when working with a client, signs of shoulder dislocation and signs of complex regional pain syndrome or shoulder hand syndrome. And CRPS refers to chronic pain an individual may have after a stroke. And on the left side of the slide here, there's a really good infographic on the symptoms an individual may experience if they have CRPS, such as pain sensitivity and swelling. And so it's just important to be aware of these because it can impact your treatment. You should also consider that depression is common after a stroke, and this can hinder recovery. And then lastly, it's important to observe the safety within the home and community of a client to reduce risk of further injury, such as a fall risk.
Moving on to the prevalence of a stroke event. A stroke is a leading cause of death for Americans. More than 795,000 people in the U.S. have a stroke each year. Every 40 seconds, an individual has a stroke in the U.S. 87% of strokes are the ischemic type, which is caused by obstructed blood flow in the brain. Some personal differences include women are at higher risk for a stroke than men, the risk for stroke increases with age, and the risk for stroke is higher for non-Hispanic Black adults as compared to white adults.
Due to the complexity of a stroke, there's a wide variety of disciplines that are involved in the recovery of a stroke patient. Specifically for the medical management and care team in the hospital setting, it involves physicians, nurses, occupational therapists, physical therapists, and speech and language pathologists. Specifically, physicians and nurses focus on medical management, testing, and continuous monitoring of the patient. When it comes to occupational therapists, they focus on ADLs, IDLs, shoulder subluxation and pain, cognition and visual perception, and sensory. Physical therapists focus on the lower extremity, mobility, and coordination, where speech and language pathologists focus on language difficulties, dysphagia, which is swallowing difficulties, and cognition.
Now we're going to jump into exploring some assessment tools that we can use with the stroke population. So the first assessment that we're going to discuss today is called the Stroke Impact Scale, SIS for short. This is a 15 to 20 minute assessment that is low cost. It also requires minimal materials, and there is also no formal training required to administer this assessment. And it can also be used by a variety of healthcare professionals outside of occupational therapy. This assessment can be done by the patient themselves or by proxy, and it's a self-report, stroke-specific 59-item scale to assess multidimensional stroke outcomes related to stroke recovery and quality of life. It assesses 8 different categories through strength, hand function, ADLs, IADLs, communication, mobility, emotion, memory and thinking, and participation. For the procedure, the administrator will read the purpose statement for the client, and then the interviewer displays the response sheets in front of the client so that way they can see as well as hear the response choices for each question. And then after each question, the interviewer can read all 5 of the response choices. But ultimately, the procedure depends on the cognitive functioning of the client. Perhaps they cannot read and verbalize the assessment, so it's necessary that you provide both, or perhaps they need to be able to see it in front of them and then go through each individual question with them as well. And then for the scoring, each item is ranked on a 5-point Likert scale in terms of the difficulty the patient has experienced completing each item within the past week. So 1 being whatever is being asked is difficult all of the time, and 5 not being difficult at all. And then it yields standardized scores ranging from 0 to 100 that is calculated for all domains, and the higher the score indicates the higher quality of life. So I have a link down here for the Stroke Impact Scale assessment form that you can download to your own computer and utilize in practice. The next assessment that we are going to discuss is called the Assessment of Motor and Process Skills, AMPS for short. The purpose of this assessment is that it is an observational assessment that evaluates motor and process skills simultaneously to see the effect on ability to perform ADLs in a natural environment. The AMPS is also a top-down assessment that involves finding out more about a client's occupational concerns and then observing the client performing that occupation in a natural environment. Through this observation process, therapists are able to use clinical reasoning skills to identify those underlying functional deficits in order to intervene to compensate, adapt, or remediate for that deficit. There are 16 motor skill items, and those skills refer to the observable, goal-directed actions that people perform during ADL task performance in order to move themselves or the task objects. Examples of this can include walking, transporting objects, or reaching for and manipulating objects. There are also 20 process skill items, and those skills refer to the ability of an individual to logically sequence the actions of the ADL task performance over time. So, examples of this can include initiating and sequencing actions, or using the appropriate tools and materials required for those tasks. For the procedure, this assessment takes 30 to 40 minutes to administer, and the practitioner conducts an initial interview with the caregiver or the client. The patient then completes 3 to 5 standardized ADL tasks that the client and the rater both agree upon. Those 3 to 5 tasks must be meaningful, relevant, and challenging to the client. Examples of Some of the tasks that the rater and the client can agree upon could be getting a drink from the fridge, folding laundry, or preparing a sandwich. Now for the scoring, this assessment is scored on a 4-point Likert scale to rate the patient's performance. The higher the patient scores equals the greater the performance of motor and processing skills. A 4 would indicate that the client performs the task without evidence of increased effort, decreased efficiency, or a lack of safety. And a 1 would indicate marked deficient performance that impedes the action progression and yields unacceptable outcomes. So next over here, I have 4 different links to YouTube videos that go through administration of the AMPS and gives real-life examples of what it would look like for someone completing this assessment. And this assessment also requires no additional specialized equipment, but it does require that you complete the scoring online. And this assessment is only for occupational therapists to use. This cannot be utilized by any other practitioners, and it does require a 5-day course to be completed in order to be proficient in administering this assessment. So the big question is, how can we use these assessments in practice? So I've divided this slide up into the 2 assessments that we just discussed, first being the stroke impact scale. The appropriate practice setting to be utilizing this assessment would be in outpatient home health and skilled nursing facilities. And this questionnaire is really quick and it requires no additional equipment, and it's used by a variety of practitioners. This assessment is also extremely client-centered, holistic, and yields quantifiable results. And then for the assessment of motor and process skills, the AMPS, appropriate practice settings to utilize this assessment would be in outpatient and home health. And the reason why this assessment is good to use in those settings is that it helps determine the capacity for independent living. It also examines the interplay between the person, ADL, and environment. And it also determines the need for OT services, homemaking, or personal care services within the home. Now that you learned a little bit more about what assessments we can use with the stroke population, we are now going to explore some occupational therapy interventions that we can utilize with this population. Our first approach to intervention that we are going to discuss is about task-oriented training. So have you ever heard of the saying that practice makes perfect? Well, that is exactly what task-oriented training is about. This approach is also known as repetitive task practice or repetitive task training. This intervention approach is based on the fact that when we practice a movement over and over, it will signal to sensory and motor neurons to adapt and create new pathways, improving motor function. So per the textbook example up here at the top, task-oriented training involves therapeutic interventions that involve practicing functional skills that are graded to challenge the client's current motor skills and improve performance in daily activities through neural reorganization. The last 3 bullet points that I have on the slide are based on a 2024 AOTA systematic review on task-oriented training for this population. So the 3 bullet points are recommendations for practice for occupational therapists for providing this specific intervention. Positive outcomes are likely observed with patients with at least 10 to 15 degrees of active upper extremity movement and able to follow instructions or have a mini mental state exam score of greater than 24. OT interventions should also include high repetition and goal-oriented functional tasks directly related to ADL and IDL. And it is recommended that task-oriented training is completed for 30 minutes a session for a total of 1 hour of intervention each week for a minimum of 4 weeks in order to see optimal results. For example, you may only have about 30 minutes in an outpatient session to provide your therapy services, but perhaps if you're working in an inpatient setting, you may have 90 minutes. So it's really important to look at what context you're in and what setting that you're working at for providing this intervention, so that way you can really promote those best outcomes for your clients. And although it may not be as fun for participants, because task-oriented training can sometimes get really repetitive and boring for clients, I would recommend encouraging them to try and do this intervention at home outside of therapy, as doing therapy alone will not promote optimal motor learning. And they really need to have that time outside of therapy where they're putting in the work so that way they can really see those optimal results. So, in conclusion, this intervention approach might be beneficial for clients who have good support systems and have their own intrinsic motivation for regaining function, because that support and their own internal motivation will help them complete this intervention outside of therapy at home. And it's recommended that this intervention also be implemented throughout ADLs. So, for example, if a client is interested in gardening, they can do task oriented training, repetitive task practice by doing the same gardening motion, or perhaps it's playing a musical instrument. But if it's not something like that, it can be something even as basic as feeding oneself or putting the dishes away in the kitchen. So there truly is a multitude of ways that we can apply this intervention approach in a lot of variety of settings.
Virtual reality is an intervention that can be used to have the client participated in goal-directed activities. The VR simulates environments that are meant to replicate the real world. The environments can either be immersive or non-immersive. When it comes to the VR, it is found to improve upper extremity function, gait, and activity participation. In a study by Kuiper, it found that providing high-level immersion VR to clients showed greater benefits than some conventional interventions. It was also found that the full immersion VR showed significant improvements in ADLs with upper extremities for stroke patients.
The first activity will be a case study. Please take time to visit the link to the Google form to apply the knowledge you have learned this far. We will now discuss outcomes. For outcomes in general for a stroke, about 90% of the neurological recovery occurs in the first 3 months after a stroke happens, and an individual's recovery can be impacted by their physical capabilities and mental health prior to the stroke, because this can affect how one copes with the impact of the diagnosis, as well as their ability to participate. And then for the specific outcomes related to the interventions discussed previously, for repetitive task practice, the anticipated outcomes are create new neural pathways to help gain function back, and then improvements in upper extremity function, balance and mobility, as well as occupational participation. And then the anticipated outcomes of virtual reality are improvements in upper extremity function, gait, and occupational participation.
When it comes to the plan of discharging a stroke patient, there are a variety of conditions that can impact where they will be discharged to. Specifically, some settings that they can be discharged to is inpatient rehab, outpatient rehab, home health, and skilled nursing facility. There are also a variety of considerations that impact where the client will be discharged to. That can be the client's home environment, the social support they have, the client's overall personal goals, and the client's current level of functioning.
Here are some examples of adaptive equipment that may be helpful to try or recommend to your clients. Some for dressing include a button hook to aid with one-handed dressing techniques, a reacher or sock aid, a dressing stick, a long-handled shoehorn, or adaptive shoelaces. Some for bathing and grooming include a handheld shower head, a long-handled sponge, a tub or shower seat to compensate for fatigue. Some recommendations for toileting include a toilet riser or grab bars, or a bedside commode. For feeding, this may look like a non-skid mat, plate guard, a universal cup, or a nosy cup. For different kitchen activities, some recommendations you may try for your client include adaptive cutting board for one-handed cutting, a rocker knife, or a jar opener. These are just a list of a few examples that you may try with your client. Now it's time to check your knowledge to see what you have learned from this presentation. Please follow this Google Form link to participate in this interactive activity that will check your knowledge after you have completed this online module.